Good afternoon, everyone. This is Professor Dunham, and I'm going to go do a exam 3 prep for you. Okay, so get your pencils and papers out and take some notes. Exam number 3 is going to cover weeks 7 to 8. So that would include week 7 would be chapter 10, and that's nursing care of women with complications after birth. And then week 7 was also the term newborn. And then week 8 is the preterm and post-term newborn. And then, of course, chapter 14, the newborn with a perinatal injury or congenital malformation. Okay, so that's quite a few chapters that you're going to be responsible for. So let's get started, okay? So go ahead over to nursing care of women with complications after birth. That's chapter 10. So what I'm going to start with you know, there's things that can happen after birth. And so they fall into like 6 different categories, okay? And so what I want to do is go over these with you. So I'd like to start with these postpartum complications. So they fall into 6 different categories, and one is what? Shock. Okay, so shock. And then we have hemorrhagic problems and hypovolemic and hypovolemic disorders, and then thromboembolic disorders, and then postpartum infections, subinvolution of the uterus, and mood disorders. Okay, so anyway, welcome everybody who just joined. All right, so this was on page 247 in your book. Now, I did send out the PowerPoint, so I hope you got them, and the little notes that went with it that you could write down some notes with, okay? So these are topics that can happen after she gives birth, all right? And the big ones, of course, is hemorrhage and the hypovolemic shock. And so I'm going to go through each one of those. All right, so here we go. So under postpartum hemorrhage, put early signs, okay? Early signs. So what are some early signs? Well, we talked about before uterine atony, or like I say it without tone, atony. What is that? I know you know it. It's a uterus that has no tone, okay? So that means the uterus is boggy and is uncontracted uterus. Now, I have also lacerations under there for early signs of a postpartum hemorrhage. And that would be a laceration is a steady trickle of blood from the vagina. So put that down, because I know I've had a HESI question about that, where they had the different types of bleeding, and laceration was a steady trickle of blood from the vagina. Then you have hematomas. Hematomas are really severe, and they're just ruthless in their pain. So we call is unrelieved pain in the perineal or rectal pain. All right, a hematoma. Remember, you went through that chapter on labor and birth, and so if the labor and birth is not good, if it's maybe has some dysfunctional labor, you're going to see these types of complications after that type of birth. Then you may have a large gush of blood from the vagina, large gush of blood. Okay, and then that's definitely a hemorrhage. And don't forget, please, under announcements and our Canvas, I put on a nice simulation of a hemorrhage. And that actually gives you a visual of what's going on. A hemorrhage, a postpartum hemorrhage, we call it PPA hemorrhage, is actually obstetrical cold blue. That's what it is. That's why I equate it to. Anyway, and then you have saturation of more than 1 peripad in 15 minutes to 1 hour. So write that down, because sometimes test questions appear as to, about the amount of bleeding she's having. And if she has saturations of more than one peri-pad in 15 minutes to 1 hour, you got a hemorrhage. Okay, and then what's the first sign that your patient is going bad on you? What's the first sign? It's her heart rate will go up. It's called tachycardia. Okay, so, and a lot of questions have been on HESI about that. All right, so I'm going to give you a little idea of what I've seen in the past on HESI. Okay, so if I was to give you a question, and I want either Ms. Johnson or Pam to answer, because they are with me today. Question is, the nurse is monitoring a client in the immediate postpartum period for signs of hemorrhage. Which sign, if noted, would be an early sign of excessive blood loss? So we just went over the early sign of excessive blood loss, right? Okay, so would it be, so your choices are A, a temperature of 100.4, 2, an increase in the pulse rate from 88 to 102 beats per minute, 3, a blood pressure change from 130/88 to 124/80, or 4, an increase in the respiratory rate from 18 to 22 breaths per minute. Which of those would be an early sign of excessive blood loss?
Is it 2?
Yeah, 2.
Yes, very good. Yes, we just went over that tachycardia, right? So she increased the pulse rate from 88 to 102 beats per minute. You got it. I bet Ms. Johnson had that too, right? So any questions about that?
Yes.
That's why you have to, during the recovery portion of, during the 4th stage of labor, that's why we check those vital signs, like every 15 minutes during that first hour, because normally after delivery, they should, the heart rate should go down. They should have more or less a bradycardia, and you see your pulse rate go up. What do you got? You got some bleeding going on. Got to check it out. Check out that fundus. Okay, so let's go on. That was very good. Very good, guys. All right, so hemorrhage and subinvolution. Well, we know what involution is, right? Yes, involution is the way the uterus contracts down, so it goes down to its pre-pregnancy, right, condition size. Okay, now what's subinvolution? Well, subinvolution just means that it's not going back down. There's something that's not right, that the uterus is saying, I can't contract back down. There's something still inside. Okay.
So an example of subinvolution would be like if your lochia is an alba color and it goes reverts back to rubra. Is that correct?
No, well, it could be. What happens is that uterus, because the progression of lochia is lochia, rubra, serosa, and alba, right? And so, yeah, that's right. Because when you teach them the discharge teaching, that's one of the alerts, is it not, Ms. Johnson? Is that the alerts is there? If her lochia goes from serosa back to rubra, right? There's something,
right.
There's something in there. Exactly. So the uterus would be not contracting properly. So that would be subinvolution. Great. She's got her nurse's thinking cap on.
Thank you.
Okay. So let's go over hemorrhage, because I'm going to tell you, you're going to see it. All right. That's my little hints to you today, because you're with me. You're going to see that. And so what would you do? What would you do if your patient had a boggy uterus?
Massage the fundus.
Yes, exactly. Massage the fundus. Great. You'll save that patient from hemorrhaging. Okay, so I've been talking about hemorrhage. So what is hemorrhage? How do we define it? Because we know it's a lot of blood, right? So for blood loss greater than 500 mLs after vaginal delivery, is blood loss of 1,000 mLs after cesarean. Now just think of an IV bag. right? An IV bag has 1,000 mLs into it, right? So got that portion. So just think she just had a baby and now you got like 600 ml bleeder. Is she hemorrhaging? Yeah, that's a lot of blood, okay? And so that would be, again, greater than 500 mLs for a vaginal or greater than 1,000 for a cesarean. And that's how we kind of quantify it. So what's the leading cause? Uteroanatomy or atoning. That's the leading cause of early postpartum hemorrhage. And early, why we stayed early is because it happens in the first 24 hours after birth. Okay, so what are we going to do? What as nurses we want to do? Well, we want to maintain good tone of that uterus. Okay, I want to make sure her bladder stays empty, don't I? Yeah, because when the bladder fills up, what's going to happen? She could bleed more. Okay, so I'm going to prevent bladder distension. So say my patient that came, she just delivered, the baby's over in the radiant warmer, and now I'm going to check her and I see a lot of blood, right? So I check the fundus. Okay. All right. Let me massage the fundus. And then I look and see, oh, I still got more blood coming out. Check that. I see the bladder. I feel it, I palpate it, and it's distended. What am I going to do? I'm going to empty it. Well, if she has an epidural, you may have to put a straight catheter in or another Foley to get that urine out because she doesn't have any feeling. You got to assess your patient to see if they have any feeling. If you can, offer a bedpan, because that's what the least invasive, correct? So we always want to do least invasive. So we offer a bedpan and see if she's going to go to be able to urinate. Okay, I want to prevent bladder distension. So write that down. And bladder distension actually will displace that uterus. Where should the uterus be after delivery? Should be midline and at the level of the umbilicus, the belly button, right? That's where it should be after delivery. Now, if the bladder is full, remember the bladder lays right underneath that uterus. So here's my uterus, my fist, and here's the bladder, okay? So when this gets full, right, what is it doing? It's pushing the uterus up. See my hand going up? And then what? I'm pushing it up and I don't have nowhere to go. So the uterus now goes over to the right. Usually it's to the right and it deviates over to the right. Now, she's bleeding. She's bleeding because that's not where it should be. It's over to the right. And so what am I going to do? Empty that bladder. So here I go. I'm going to empty the bladder and it goes down. And what happens here? See my fist, my uterus is coming over. And what? It's coming right back down to where it should be. Now the bladder is what? Empty. And my uterus is back in midline at the umbilicus. Very nice. Okay. So, and what happened to her bleeding? It normalized. She stopped hemorrhaging. That's what I want. That's what I want. Okay. So there's usually a good question about that, just to give you a heads up. All right. So what kind of drugs you're going to give? Well, we're going to give Pitocin, which is a synthetic form of oxytocin. Even though her body's probably going to release some, I'm going to give her a whole bunch. I want to get that uterus contracting. Those are prostaglandins. I want to get them contracting. I may give her Methogen. Now remember Methogen. Methogen it's really intense. So you give it IM and it works quick. I'm going to tell you it does work real quick. But the main thing about Methogen, guys, is that you have to remember what's her blood pressure. What's her blood pressure? Because the blood pressure can go up on giving Methogen. And then there's a couple other, you got Hemabate and Misoprostol. Those are all good forms of what? Prostaglandins that go ahead and contract. So, any question about Pitocin or Methogen? Okay. Just remember with Methogen, you have to what? Make sure that you monitor blood pressure. So I couldn't give it to a woman with what? Hypertension. No, I could not. So I would have to give her something else. Okay. So the next area we're going to talk about that causes hemorrhaging is retained placenta fragments. All right. Now, retained placenta fragments is what it is the placenta that came off that intrametrium that, comes out and you look at it. Okay, so the nurse's responsibility is to look at it. Okay, let me just see something here real quick. Okay, so the nurse's responsibility is to look at the placenta. So I've got one side, I got the maternal side, it's called the Dirty Duncan. It's called the Duncan. I learned it many years ago. About my teacher said, you remember it this way. Mom's side is kind of dirty looking. It has a lot of lobes to it, right? So we're going to call that the Dirty Duncan. And then the neonate side is called the Shiny Schultz. Okay, so I'm going to look at the placenta comes out. So here it comes. Here comes my placenta. Going to deliver my placenta. I'm going to look at that placenta, and I'm going to look at all the different lobes. See, I'm looking, see my finger going around, making sure that everything's intact. Now, if there's something missing in that lobe, okay, then what do I got to do? I got to tell the doctor, hey doc, we're missing part of the placenta. And he goes, oh, thank you. Because where is it? It's still up in the uterus. And if we didn't pick that up, she could hemorrhage. And that does happen. When people don't check that placenta after delivery, and there's some fragments still up in that uterus, that causes them to bleed, and to bleed heavy. So again, that could cause a hemorrhage. Okay, and how they do, they go up right after delivery, they'll take like a curettage, and they'll do like a mini curettage there, and they'll take like a ring forceps, and what they do is they take a 4x4 and they square, fold it in fourths, okay? So it makes a nice little gauze, and they take it and go up inside the uterus, and they do what we call a clean sweep. Just go around the uterus and they bring it out. Now what they got is a specimen. So I don't touch it. I have a little jar, sterile jar, and the doctor just puts it right into the sterile container. I label it properly, and I put on, placenta fragments. It goes to pathology, and then they will study it, and they'll confirm that we did get it. Okay, the reason why is because we want to have documentation that we did it. Okay, the next thing I'm going to talk about is lacerations and hematomas. Now, unfortunately, you may have a big baby, may have some dysfunctional labor, may have some shoulder dystocia delivery. Big babies, they cause mom to get lacerations up inside the vagina by the cervix. So that can cause them to bleed. All right. So lacerations, like I said in the previous slide, is a trickle of blood, and it is. You ever have a faucet in your faucet? Well, in your sink, the faucet, and it just kind of dribbles. Well, it's the same thing that occurs up inside the woman, is that this laceration just keeps trickling. Okay, there's nothing to stop it, so she can bleed. And then hematoma is a collection of blood, and I do a couple of slides down, I'll show you a nice picture of a hematoma. All right, hematomas, again, they are ruthless. You could give a patient oxycodone, maybe some Percocet, and it doesn't even touch it. Okay, another problem with hemorrhage and subinvolution would be an inversion. Oh my goodness, let me tell you, after delivery, you have a big baby, and all of a sudden, everything comes out, and all of a sudden, also what comes out too is the uterus. It's called an inversion. Do we want that uterus outside the body? No, it's not supposed to be there. So it's another obstetrical emergency. It's never fun. And you have to get anesthesia in there real quick, because either one, they'll give her like a twilight sleep to relax the patient so we can go ahead and push it back up, or we have to put on a general anesthetic to try to put the uterus back in. And sometimes if it's really bad, we have to do a hysterectomy. But that's the last, excuse me, that's the last thing we resort to. And then the other problem is subinvolution. And we already went over that quite a bit. But again, just to reiterate, it's just that there's a problem that's not allowing that uterus to contract to have the involution process? Is a slow return, or is there something involved? Okay, so that's called subinvolution. Now over here, there's the 4 T's that are associated with hemorrhage and subinvolution. And one T is tone, T-O-N-E. So write that down. These are ways to remember what causes a patient to hemorrhage and to have subinvolution. And so tone would have to do with what? Uterine atony or tony, A-T-O-N-Y. Okay, then the next T would be tissue. That's retained placenta. Okay, then the next T, trauma, which we talked about, was lacerations. And the last T is thrombin, which is what? Coagulation properties, in which she's a free bleeder and she doesn't have the ability to what? To coagulate, to clump up, and so she doesn't bleed. Okay, any questions about hemorrhage and subinvolution? Okay, so let me give you a question. You ready? Okay, so the postpartum nurse is caring for a woman who just delivered a healthy newborn. Okay, the nurse should be most concerned about the presence of subinvolution, right? If which occurs. All right, so let's see how we do. After pains. Number 2 is retained placenta fragments from delivery. Number 3, an oral temperature of 99.0 following delivery. Or 4, increased estrogen and progesterone levels as noted on laboratory analysis. So what is the primary cause of subinvolution?
2.
2. That's right. 2. That's absolutely right. Retained placenta fragments from delivery. I think you got it. All right. Good job. Good job. Okay. So I know we're kind of beating this little horse to death, but I guess it needs to get done. Uterine atony or atony. Okay. Remember, for 3 little letters, FFP. Okay. So when I have a uterus that's soft and boggy, I'm going to look for the first F would be what? Fundus. Fundus. I'm going to massage that fundus. All right. Number 2 is I'm going to insert that Foley catheter. I'm going to take down that bladder. Make sure it is deflated. And the last one is P for Pitocin. Pitocin. Okay. How about we do another question? You ready? All right. On assessment of a postpartum client, the nurse notes that the uterus feels soft and boggy. The nurse should take which initial action? Okay, so you're going to document the findings, elevate the client's legs, massage the fundus until it's firm, or push on the uterus to assist in expressing clots. Okay.
3.
Who's that 3? Who's that 3?
Dorinda.
Hi, Dorina, how you doing? You are absolutely correct. Okay, so now, if you see this on a HESI and you get it wrong, I'm going to come after you all, because I think I've said this in every slide going. Okay, so what in doubt, you massage that fundus, right? That's the initial intervention, is to massage the fundus until it's firm and to express clots. Okay, did you have a question, Pam? Let me just see here. Anybody? No. Okay. Oh, Pam, thank you. She said 3 also. Okay. Thanks for putting it in the chat. All right. So that's good. So we got that. We got that. We remember that. Okay. All right. So I'm going to talk about postpartum hemorrhage. And if you have this PowerPoints up, you can see the picture of a hematoma. It is not pretty, is it? Okay. So just imagine the hematoma after delivery. Oh, it's so painful, guys. I had a patient, let me tell you of an incident I had. I had a patient that after delivery, she had a big baby, by the way. And we had a vacuum extractor. All right. And so what happened is that she developed a hematoma, and it was so huge. She didn't want to She didn't want to go to the bathroom. She didn't have a bowel movement, and we did everything we could. But the cis bath was her friend. Okay, so let's talk about lacerations and hematomas. They're the second leading cause of a hemorrhage. So write that down. Write that down. Laceration and hematomas, second leading cause of a hemorrhage. So lacerations. So you have this, and you can get them in the cervix, the vagina, the perineum, often with operative birth or precipitous. Ah, precipitous. So remember what a precipitous labor birth is, right? It's quick, is it not? It's quick. So is labor and birth within what? All within 3 hours. So that baby, you know, not only is she having so many contractions, and the baby comes down quick. And so what happens that after she not only should get a laceration from the baby descending so quickly, is that so much pressure is being exerted so fast. And then the uterus can get very soft and boggy after a precipitous, because the uterus has been contracting. It's been one after the other, right? One after the other. And so what happens is that when all those contractions, the uterus now gets what? I'm tired. I've had it. So we go ahead and you can get a hemorrhage after that. So you can get a soft, boggy uterus. If you have an episiotomy or first degree, second degree, third degree, or fourth degree. So the category on that, on the laceration episiotomies, you can also get a you have lacerations and you have hemorrhage, and it's not pretty, is it? No. And then you have another thing, you have to prevent constipation. If you got a patient that has a laceration hematoma, you're not going to use, do not use suppositories or enema. No, no, no. So there's a third or fourth degree, you do not use enemas, and you do not use suppositories. So what are you going to do for her? You're going to increase her what? Diet, fiber in the diet, correct? And drink lots of fluids. That will help move that around. Okay. Now hematoma. A hematoma is collection of blood in the connective tissue. So you've all probably seen a hematoma. It's a bluish purple bruising, and it's swollen. So I'm going to give you see my hand, and so it's swollen. They're quite big, almost like the size of your fist, and they're just nasty and they hurt. Pain is the most common symptom, and most common is in the vulva. So you imagine that's such a sensitive area to begin with, and then you got this collection of blood that's just going to take time to go down. Okay. All right, and then we talked about inversion of the uterus. Again, this is all leading up to what? Postpartum hemorrhage. So inversion of the uterus, you got to do some really vigorous fundal pressure, and what happens is that you got to put it back in. So it could be that maybe during the delivery you had a lot of fundal pressure put on. Now, sometimes when the baby gets stuck down and he's almost ready to be born, just mom can't push it out. So doc says, you know, go ahead, Pam, and use that fundal pressure. So you put your hands on the fundus and you press down. Well, that can cause an inversion of the uterus, could it not? You got the visual picture? So she's using this fundal pressure, and it's pretty hard too, and you can invert that uterus. Another way you can invert a uterus is excessive traction on the cord. So what happens is that the baby comes out, and now the placenta, you know, it takes time for that to come out, and a lot of doctors don't want to do it. So they take a hemostat and they start wrapping the cord around the hemostat. Okay. And then they kind of put a little pressure traction on the cord, and they pull on that. And you know what happens? You can pull everything out. You can pull that uterus out. What do you think about that? Anybody? Anybody? Well, it's pretty bad. I mean, it is a obstetrical emergency. Yeah. And so, like I said before, you know, you got to get anesthesia in there. All right. And then again, another term, again, I'm going to say is subinvolution is failure of the uterus to return to pre-pregnancy state. So that's one. Number two is you have prolonged lochia or bleeding. Now, say she goes home, okay? And because you only have these patients like two days and 3 days if they had a C-section. So they have like prolonged lochia at home or bleeding that they shouldn't have like a home, right? Too much. That's called a late hemorrhage. That's like greater than 24 hours. So early hemorrhage is defined as bleeding that occurs in the first 24 hours. And then late hemorrhage is bleeding that occurs after 24 hours. So that's why you really have to do a lot of discharge teaching about the bleeding and how it should go from lochia rubra to lochia serosa to lochia alba. And we talked about this before. I think Ms. Johnson gave the right answer. She says, yeah, you have to make sure that they know that going from serosa back to rubra, that's not correct, right? That's not right. It should not happen. Okay. Okay. Let's go on. Any questions so far? Everybody okay? Give me a thumbs up on the reaction screen. All right. So we did this one. Let's go here. Okay. All right. Let's talk about, oh, thank you. Thank you for the reaction. Hypovolemic shock. Okay. So let's go over the signs and symptoms. And I tell you, write them down as I say it so that you have it. Okay. So signs and symptoms, the first one is tachycardia, is that heart rate will go up. And it shouldn't be, right? Remember we talked about it earlier, it should be low after delivery. So if you've got a patient that goes like from 80 up to what, 100, 120, we got a bleeder on our hands. Okay, so tachycardia. Then her blood pressure will go down. Blood pressure will go down and you get what we call hypotension. Hypotension. And then you have her getting pale. Well, that kind of is a good indication that something's happening. She's losing color, right? She's losing blood. She's bleeding. And then the skin gets involved and gets cold and clammy. Remember, the body is like yelling for help. Help, nurse, help me. And then you have mental status changes. Does everything in the body, all the organs need what? Blood. Right? Blood carries oxygen. And so you need everything needs blood. So if you're not getting enough blood to the brain, you're going to get mental changes. Okay. And then of course the kidneys need blood to operate. So you'll have a decreased urinary output. All right. So again, the body is saying, help, help, help. Okay. So how about a question? So the nurse is monitoring a postpartum client who is bleeding for signs of shock. Okay, which indicates an early sign of shock. All right, complaints of an abdominal cramping, an increased pulse rate of 80 to 120, complaints of feeling tired, but yet she's feeling hungry, and an increase in the respiratory rate from 18 to 22 breaths per minute. What do you think is the right answer? Okay, how about Ms. Johnson? Give me, what's the right answer? Pam said 2. Dorina, what you got? What do you think? Okay, so it's 2. Is an increased pulse rate of 80 to 120. Okay, if you were listening to me, that's what I said, didn't I? Good, Pam. Okay, all right. So that covers hemorrhage, uterine atony, lacerations, hematoma. So that was basically chapter 10, the beginning. And so let's go on and talk about postpartum infections. All right. So it comes right from your book and it's it's in your book on page 254. So, yep, and it's table 10.2, and that's what I use too, 10.2. So what happens? Okay, so basically, what kind of precautions are going to be used to help prevent a postpartum infection? What kind of precautions? Well, that would be standard. Write that down, because you might see that again. Standard precautions help prevent postpartum. So what are standard precautions? Pam, help me out. What are standard precautions?
Like washing your hands and wearing gloves.
Yeah, exactly. Very good. Yeah. So make sure that everybody washes hands in the room, right? So if anybody comes in and says wants to come and visit, right? Like everybody does, make sure that everybody washes hands. Okay, that's your responsibility as a nurse. Okay, and it's okay. Just say, I don't think you washed your hands today. Did you wash your hands? And so you want to make sure. Okay. Okay, what else about a postpartum infection? It occurs within 28 days after a miscarriage or induced abortion or birth. Okay, so again, a postpartum infection occurs within 28 days after she has a birth, or miscarriage, or induced abortion. All right, so we got to be careful. So what happens? You get a fever. What's the guideline for that fever? 100.4. Okay, 100.4. Write that down. 100.4. So you have 100.4 or greater. You're dealing with a what? Postpartum infection. Okay, and you have 2 days with a high fever, and it can occur after what? 24 hours. Okay, so we got to be on alert for the infection. Okay, so what are 2 signs of a postpartum infection? What are some signs and symptoms?
Fever.
Yeah, fever. Yep. Just think of yourself when you're really sick, okay, and you're running a high fever. You what else? How else do you feel? Feel tired, don't you? Yeah. Get really tired. Yeah, you don't want to deal. You don't want to eat. Just want to what? You just want to go sleep. Okay. So, what is another very common infection situation? Like, I'm looking for what can happen inside that uterus. So let me tell you, the most common for postpartum infection is endometriitis. So just write that down. Remember, we talked about that endometriitis, and it's an infection, what? Of the lining of the uterus. Okay. And it begins at the placenta site. Remember, the placenta breaks away from the endometrium, and you have all that open area tissue. That's why you want that fundus to be nice and firm, because that's actually putting pressure on that placenta site. Okay. And that's where that infection can be. So that's why we don't do too many badge exams. That's why we don't go up inside the uterus with any kind of hand, because even though we have sterile gloves on, we are still going through a dirty area, the vagina, to get there. So the bugs can get in there. So we keep out of it. Okay. And then a lot of times she can get a postpartum infection from a cesarean. Yeah, every time you do surgery, you're opening the body wide open for infection. Okay, so I'm going to give her, like, maybe they get prophylactically, they'll get antibiotics with a cesarean. Okay, then you have abdominal tenderness. Oh, yeah, the abdominal area is very tender to touch, and they may have some pelvic discomfort. And big one, foul smelling discharge. So let's write those down, okay? I want to make sure you get this. For endometriitis, you have abdominal tenderness, number 1. Number 2, you got pelvic discomfort. Number 3, foul smelling discharge. Always indicates an infection going on. And then you have subinvolution. Okay, remember we already talked about that. And so these are things that can happen with endometriitis. Okay, any questions on endometriitis? Okay, all right. So now I'm going to go on to another infection, and that's cystitis, urinary tract infection. All right. So, how are we going to get around that is we teach proper what? Perineal care, and then increase fluid intake. Okay, so we want to make sure that, we get her to use that peri bottle every time she urinates. So keep the bacteria from going anywhere, and then increase fluid. Okay. Now, you may have a wound infection. You may get that from the cesarean section site, or laceration, or episiotomy. And the other one I talked about is mastitis. Yeah, mastitis. That's pretty bad. And there's a good picture on page 255 in the textbook that shows you the breast and how you can see how swollen it is, how red it is, and it's very, very painful. So how are we going to prevent that? Well, remember we talked about, we want to prevent that by making sure the baby latches on correctly, right? Okay. That he's not just playing with the nipple, hanging on to the nipple, and mommy's going to get redness and cracked nipples. And then from cracked nipples, they get infection. And then she's got mastitis. And then she's got a fever, there's warmth, redness. You can even see that like a little pie wedge to it. She gets like a flu-like symptoms, and she could have purulent drainage. So you couldn't breastfeed. And I tell you, women have mastitis, they don't want to really breastfeed out of that breast, even if it didn't have purulent drainage. It's just too painful. And so what are you going to do? Well, if she got purulent drainage, we're going to give her some antibiotics. And how about some analgesics? Yeah. Frequent pumping and warm compresses. So yeah. Oh yeah. They could do, in order to avoid a mastitis, they could always make sure that the flow of breast milk is flowing properly. And a lot of times they can take a warm shower before breastfeeding, and that helps. And it cleans the breast really good, and it does help the flow of milk. So that'd be one way to maybe help her out, so she avoids a mastitis. And then a support bra, because they're heavy, and then encourage hydration. Okay, so that's for the treatment for mastitis. All right. Now, while we're here, because postpartumly, if she has an episiotomy, we need to what? We need to assess that really carefully in order to avoid another infection, right? Postpartum infection. So when we look at the episiotomy, remember REDA, R-E-E-D-A. So write that down, right? R, and then E, E, D, and A. And R stands for redness. E stands for edema. And the other E is ecchymosis, when you can put in parentheses bruising. And then D is your discharge or your drainage. That's your lochia. And then A is for approximation. So this is what we're going to look at. And also for D, for discharge, it could be that make sure there's nothing that's seeping from the episiotomy. So redness, if it's red, inflamed, warm to touch, you got an infection starting. If it's real swollen, what can you do, right? Well, for an episiotomy, the first 24 hours, you put ice on it. Boy, that feels good. Takes down that edema and helps with the ecchymosis. And then you want to make sure that you do look for any kind of discharge or drainage from the episiotomy site, because that's never good. And then approximation, that means how the tissues, were approximated together to close. Because don't forget, they were open, and see my hands, this is well approximated. And then, because sutures, they kind of give, so they can kind of open up. So if you see a millimeter, 2 millimeters that are a little gapping, you want to report that to the physician. Okay. And What can you do that's an independent nursing intervention? Would be what? Keep it clean. Make sure she does her pericare. Okay. How about another question? Okay, you right? You ready, guys? Okay, the nurse is monitoring a postpartum client who is at risk for developing a postpartum endometritis. So which finding, if noted during the first 24 hours after delivery, supports a diagnosis of postpartum endometritis? Would it be 1, abdominal tenderness and chills, 2, increased diuresis and appetite, 3, a maternal oral temperature of 100.2, or 4, fundus, 2-finger breasts below umbilicus, midline and firm? So what do you think? Which one would you think that she is? What's the question asking me? So I go back and look at the question. So which finding, if noted during the first 24 hours after delivery, supports a diagnosis of postpartum endometritis? Pam, you got right. Dorina, what do you think? You are correct, Pam. It is 1, abdominal tenderness and chills. Good. Okay. And well, what other signs and symptoms will we have? We would have delayed uterine involution. So you'd have subinvolution, foul smelling lochia, and tachycardia. Okay. So that would be infection. All right. Good deal. Good deal. Well, we're moving right along here. So let's look at some thrombus. Let's look at some DVT, some superficial venous thrombus, and how about a pulmonary embolism? All right, these are things that can happen. And so what we're going to do, if we have a superficial venous thrombus, what does that involve? Well, that involves the superficial saphenous venous system. You know, your saphenous venous system is large. It goes right down the leg. And what happens is you have pain and tenderness in the lower extremity. Yeah, it goes straight down the leg. And then you have warmth, and it may be red, and it may be enlarged, hard vein. Okay, so that saphenous vein is huge going down the leg. So again, you got pain, you got tenderness in the lower extremity, and then it's red and it's warm and it's enlarged and it's real hard. So how are you going to treat that? Well, some NSAIDs, rest and elevation and compression. Those compression stockings. Okay. Then another one that's very common is, well, not very common, but it's more that we see. We don't see too much of the others, is the deep vein thrombosis. And that's called a DVT. Now that can extend from the foot to the iliofemoral region. Okay, right up until where? What, iliofemoral, right into the groin. Is most common in pregnancy. So what you have is you have a unilateral leg pain. Okay, and calf tenderness, swelling, and it's red and it's warm, and is you have a positive Holman sign. So how are you going to prevent it? Is early ambulation to prevent. And how are you going to treat it? You're going to treat it with an anticoagulant therapy. Maybe some IV heparin. Okay. So that's more common in pregnancy, is that DVT. And that's what we worry about. All right. And that's why the patients say, I had patients on postpartum or mother baby unit. And I had one patient that she was crying. So I ran down to the room to find out what was happening. She complained of, pain in her calf. Okay, and it was just on the one leg, and it was slightly swollen. So I said, okay, I called the doctor right away, and we got a venous Doppler, and we did a venous Doppler test, and thank goodness it was okay. It was negative. Okay. But you can't just say you'll be okay, right? No, we have to find out what's going on. And then the other problem you could have is a pulmonary embolism, and you know it as a PE. And what happens is that you have like a DVT in the leg, right? And what happens, it loosens up. It kind of gets loosened up and it travels right to the pulmonary artery. And what happens, it obstructs the blood flow to the lungs. It's a blockage. And what you get is you get dyspnea, difficulty in breathing, and chest pain. You get tachypnea, and which is, rapid breathing, and then you get tachycardia. So this is really serious. That's why, back to the DVT, if somebody's complaining of that leg pain, I'm not just gonna say, oh, you'll be fine. Oh no, I want to know why. And that's why I call the doctor. I get a venous Doppler. I want to know what's going on, because that DVT can break loose, and it does. It just breaks loose, and it travels right into the pulmonary artery, and then it blocks the blood flow to the lungs. Okay, so if you get blood flow is blocked to the lungs, so you get diminished going to the lungs, you're going to get chest pain, because it's just you're not getting what you need to be getting. You're going to have difficulty in breathing. And because I'm getting scared, I'm going to get tachypnea. And then because I'm really scared, and my heart is saying, what the heck's going on here? I'm going to get tachycardia. So that all goes together. And the reason why we're very aware of all this is because this is a major cause of death to mommies. Okay, maternal deaths, not good. And it's most common in the postpartum period. So this is an emergent situation. So you're going to get anticoagulant therapy, which is IV heparin. And then she's going to be on oral anticoagulants up to 6 months. So not good. All right. So does everybody see the difference between an SVT, which is your superficial venous thrombus, your deep vein thrombus, which is your DVT, and then your pulmonary embolism? Do you know now the difference in them? Okay, Pam gave me a thumbs up. Good.
Yes.
All right. Good. Thank you. Yeah, good. So how about a question? You ready? All right. The nurse is developing a plan of care for a client recovering from a cesarean delivery. Okay. So which action should the nurse encourage the client to do to prevent thrombophlebitis? Okay, so should I have her elevate her legs? Should I have her remaining on bed rest? Should I have her ambulate frequently? Should I have her apply warm, moist packs to the legs?
3,
3, absolutely. All right, I'm so proud of you guys. Good deal, both of you. Yes, ambulate frequently. And that's for all surgeries, isn't it? If you're in med surg, you're gonna be studying this also. Okay, all right. Because when you're not moving and you're in a state what we call stasis, and that means you're not moving, that puts you at a high risk factor, predisposing factor in the development of thrombophlebitis. So you don't want to do that. So what are you going to do? You get her up out of the bed and move. And we do that now with all patients, even cardiac patients. We get them out of bed. And so therefore we get that blood flowing. Okay, blood flowing. All right, everybody good on now infections and DVT? Remember, you got your little unfolding case study, but let's go now to mood disorders. Okay, so it happens. You got the baby blues, postpartum baby blues. Moms are emotional. Sure they are. Cries easily, anxiety, sadness, difficulty sleeping, and fatigue. Okay, everybody got that? So you continue to bond with the baby. Okay, so I'm interested in the baby, right? I'm good. And it peaks around the 5th day, and it kind of subsides around the 10th day. And it affects about 85% of women. And you know, it doesn't impair functioning. She can still, she does a lot of things, but she's just what? Just blue. Mhm. Why you think I get this? You know, what? Because I probably don't get enough sleep. If you've been a new mom once in your life, you don't get enough sleep. No way. And then you're not eating probably properly. And because you're feeding the baby all the time, you have no more time, right? And so you're not sleeping, you're not eating. And every time you try to take a shower, you can't because you have to have somebody there with the house with you. You're too afraid to take a shower, leave the baby alone, you know, things like that, right? So you kind of get a little boot down. All right. So thank goodness the 5th day, it kind of peaks. And then by the 10th day, now you're getting more into routine. And the baby is too. Everything's new to both mom and baby. All right. Now, we go into postpartum depression though. So now we're getting more what? Intense sadness. And this now has severe mood swings, severe mood swings. And it lasts more than 2 weeks. Okay. So now she's not getting any sleep. So insomnia, loss of appetite, these are all what? Increasing. Remember, postpartum blues, it was gone about the 10th day. This now continues and is now going on more than 2 weeks. And so, you know, a lot of ladies get really down. And sometimes thoughts, just thoughts of self-harm, you know, but they need to reach out. That's where I always said in the hospital, when I did the mother baby unit work there, I always said, it's great that you're all coming up here to see her in the hospital, but we're here. Okay. Why don't you save your visitation so when she's home and she needs a rest and she needs help, she needs to take a shower, that you're there rather than everybody coming to the hospital and see the baby. Okay. And it really doesn't very often she needs help. It stays with them. So really rarely disappears without help. They need help. Okay. And sometimes they're so down, they have feelings of detachment or a lack of interest toward the newborn. So that's pretty bad. Okay. That's why they need help. And then psychotherapy and sometimes antidepressants may be necessary. So we want to avoid mommies getting postpartum depression. And also you have to take note that if she had depression before she got pregnant, it's probably going to escalate and get worse afterwards. So a patient that comes in and says she have a history of depression or anxiety, I kind of, want to take note to that, because after delivery, I'm on the outlook for this patient. I'm keeping an eye on her. And honestly, on the mother baby unit, we do have a depression scale before they go home that we fill out. And so if they need help, we can intervene right there at the hospital. So it's good. Okay. And then we got the last one is called postpartum psychosis. Okay. This is where they have some psychiatric involvement. Oh my goodness, they may hear voices. It's associated with bipolar disorders. It's a rapid onset of bizarre behaviors and either visual or auditory. And like I said, they hear voices. And then hallucinations, some paranoia, delusions. And unfortunately, they have high risk for suicidal ideations, or we call it infanticide. And so mommies are told, they hear voices and say, this baby is not your baby. This baby is a product, from Satan, or all kinds of different stuff they hear, and you need to get rid of the baby. And so that happens. We had a case in Texas many years ago where she drowned her children, things like that. And she went to trial and she was committed because of this postpartum psychosis. That's when it really came about. And we started talking more about mental health and how women were out there needing help really severely. And sometimes you have to, most of the time you have to have antipsychotic drugs and mood stabilizers to help. It's very sad, honestly. So they need that help. Okay. All right. So that is the end of chapter 10. And so again, you want to look at your unfolding case studies and do that. It does help. Okay. So let's move on. And we're going to talk about newborns. All righty. So that would be what chapter, I think chapter 12. So let me get my book. So we all follow along in the book. All righty. And newborns. So reflexes. So you can refer to page 286 and it's table 12.1. So and have a really nice table on reflexes. Okay. So let's start out with some reflexes. So again, the biggest job this baby has in being born, right, is breathing. Okay, so we have to help that baby to breathe. And so so this is where it comes out. So let's go ahead and look at the different reflexes. So you have on page 285, you have some reflexes here. You have the head lag, where, you know, we can see how you lift the baby's arms up and his head kind of lags that way. And this newborn, as you see, is on figure 12.1. He has some ability to control his head in some positions, and that's nice. And then you have the Moro reflex, or the startle reflex, where you hit the crib on a surface and the baby gets startled and his arms go up like this and his little hands are in like the shape of a C. It's like, ah, you startled me. That's a Moro reflex. And then you have the grasp reflex, where his hand, you know, the grasp. And you know, reflexes they're all part of the neurological system. So if you have absent or diminished reflexes, you guys maybe hypoxic episode that occurred, and so you know you've got some problems going on. So when I had that one patient that had a shoulder presentation and the shoulder was coming through, you know, and I checked her and I put my fingers up to check, and all of a sudden the baby came down, his hand was there, and what happened, he grabbed onto my fingers. Well, I said, oh, that baby has a really good grasp reflex, but it was a stat C-section, by the way, because the baby was coming down in the wrong presentation. So that's what happens. And then you have what's the eating one, the rooting reflex, where you just brush your hand across the cheek of the baby, and he goes to root. He knows that, oh, where's my food? Yeah. And another good reflex is called the sucking reflex. And the sucking reflex is one of those that are needed to survive. Okay. And so these reflex, such as blinking and gagging and sneezing and sucking and grasping, those are all what we call very important reflexes. And then the reflexes that helps keep them ongoing is they can cry, they can swallow, and lift their head slightly on their abdomen. Okay, so those are your reflexes. And then you've got the little dance one there. And that's what I always had patients when they said, it's called the stepping reflex. And they said, oh, my baby is so smart. My baby can walk. No, your baby that's a reflex. He feels on the bottom of his foot, he feels his foot touching a hard surface, a cool surface, and he goes, ah, okay. And so he's like walking. And so that's called stepping. Now, another one that's important, and I want you to write down, is called the Babinski reflex. And that's when you stroke the sole of the foot and the big toe will dorsiflex, and the toes, they flare out. Okay, so that one is at birth, and it does go away. It's variable, but it will go away before the infants actually start to walk. Okay, So the Babinski reflex. So I would write that one down because you might see that one again. Okay. That's another hint, right? Okay. All right. So how about we do a question? Ready? Okay. So which of the following describes the Babinski reflex? All right. So here you go. A, the newborn's toes will hyperextend and fan apart from the dorsal flexion of the big toe when one side of the foot is stroked upward from the ball of the heel and across the ball of the foot. Oh, that sounds pretty good. Okay, or is it B, the newborn abducts and flexes all extremities and may begin to cry when exposed to sudden movement or loud noise? Well, I think that was the what? Which one do you think that one? That was the Morrow reflex. Okay, then number C, the newborn turns the head in the direction of the stimulus, opens the mouth, and begins to suck when the cheek, lip, or corner of the mouth is touched. Well, we know that one is, right? That was the rooting one. And then you have the next one. The newborn will attempt to crawl forward with both arms and legs when he's placed on his abdomen on a flat surface. So, oh, I see everybody's going to join in. And yes, Pam, it is A.
Yeah.
I know, is A. The newborn's toes will hyperextend and fan apart from the dorsal flexion of the big toe when one side of the foot is stroked upward from the ball of the heel across the ball of the foot. Okay. So you won't get that one wrong, right? Right.
No.
Okay. All right. So that's reflexes. And remember, on the fontanelles on the baby, there's a good picture, and that's on like page 286, 287. It shows you the picture of the fontanelles, 287. And you got the interior, which is your largest fontanelle, which is in the shape of a diamond. And then you have the occipital, the posterior fontanelle, and it's like in a crescent. But one thing you have to remember about fontanelles, if the fontanelle is sunken, it means it's down, sunken. That means the baby is dehydrated. Write that down, dehydrated. Okay, if the fontanelle is bulging, that means there's too much fluid in the cranium. And that could be from a condition of hydrocephalus. So you don't want it bulging, and you don't want it sunken. Okay. And remember, it takes time for those things to close, and we don't want anybody pressing on the baby's head. Like, oh, what's that? What's that? No, no, no. That's very, very bad. And you don't want anybody putting any holes in your baby's fontanelle. Okay. So bathing. Let's go on to bathing this little guy. All right. And you can read about how to measure the head and everything. All right. So let's go. Okay, so the first bath is on page 300, skill 12.5. And so you get a little sponge bath, and or you have a tub bath. You can get, a sponge bath. You want to be very careful when you still have the cord on, because why? You want that cord to remain dry, because it crosses over and falls off. And this is what you got to remember, because I know this is like a lot of test questions, is you wash the head last. So write that down. The head is the last thing that gets washed. And why? I mean, let's not just memorize it. Let's talk about why. It's because the head is the largest part of the body, right? The baby's body. Okay. And when you wash something, doesn't it get kind of cool? Yeah. And so if you wash that first, say, that baby's gonna get what? It's cold stress on you. So that would be the last thing that I would wash, because I'm worried about him losing the heat. You get a lot of heat loss right through the head. So you want to do the head last. Does that make sense?
Yeah.
Yeah, yeah. And then when you're doing a bath, that's a great time to teach mommies about how to give a bath. And then, eye and ear care, taking care of that. And then infants, they don't get too dirty. I mean, they probably need a bath 2 to 3 times a week. Okay, and you can just use water, you know, their little skin is, you don't want to dry them out. And then again, how you wash it, and this could be, I think NCLEX likes this kind of term, is called cephalocaudal. And what that means, that's head to toe. And I'm going to spell it for you. Are you writing it down? C, like C as in cat, E, P, H, A, L, O, C, A, U, D, A, L. That means cephal is the head, caudal down to the lower, down to the toe. Okay, so that kind of makes sense. And then of course, cord care. Want to make sure it stays nice and dry and clean too. You don't want any infections to occur there. All right. Now let's go over to the gastrointestinal. All right, and so we have to be responsive to the feeding of the baby. Now, feeding behavior is related to the gestational age of the infant. So can they suck? Are they breathing? Can they swallow? And are they are they responsive to feeding cues? Now, when you have a pretermer, they have harder times. Okay, but their sucking reflex may not be there. Okay, and so they may have to be fed a different way. Okay, and so it's all according to the gestational age of the infant. And then again, you have your intestinal microintestinal flora, and so the flora gets established within the first week to synthesize vitamin K. So babies are not born with that. So that's why we give the vitamin K injection in the beginning, so that they don't hemorrhage. And then you got mucus, the mucus barrier in the intestine is not mature until they're 4 to 6 months of age. Okay. So remember, these little guys, I mean, they went through a lot in utero to get where they are. Okay. And so, but it takes a little longer now after getting out of utero to for things to really develop in their body systems. So that's why they have small little stomachs, and you can't overfeed a baby, because then you would just just bring it back up to you. Okay. And so all this would increase the risk of allergens and infection. So I hate to see babies go out to the mall when they're just born, because they're so prone to an infection. And so you don't want that to happen. And of course, breastfeeding is the best, because you get the antibodies and helps them their immune systems. Okay, because remember, babies are only born with passive immunity for only 1 month. So they need that right from the beginning. And then they have the reflex of the gastroesophageal reflex, or we call that spitting up. That's called the gastro, GASTRO -ESOPHAGEAL. And that's spitting up. If you feed me too much, I'm gonna see you again. I'm gonna bring it back up to you, okay? Because you overfed me. All right. So that's why you can't overfeed it. A lot of women, people overfeed, especially with bottle feeding. They seem to overfeed a lot. And then you got stools. Okay. So we know meconium. We talked about that. That's dark and like tar. You ever see tar on the road? I always think of meconium. And it's in the first 48 hours. Okay. Then you have transitional, which are looser. They're greenish, yellowish. Okay. And then on the 4th day, they usually get yellow and seedy. They're more seedy with breastfeeding than they are with milk. Milk is basically, the formula is usually a heavier looking stool. Now, that's why I always say to moms, breastfeeding, your baby stools are going to be better for the baby so he does not so heavy, and it actually smells better than formula does. Okay. And they should be having like 3 to 6 stools per day. All right, and in your book, I know there's a great chart on how the stools change. And so I know you know where that is. Okay. All right. Let's go on. So let me give you a question. I like this, right? The nurse is caring for a breastfed baby. Okay, newborn. All right. What will the nurse expect the stool color to be 5 days after birth? Okay, would it be yellow? Would it be brown, black and tarry, or greenish brown? What do you think?
Yellow.
Yellow, yes. Pam, are you agreeing with that? It's yellow. Okay, good. So you can see how these questions would be asked. Okay, so that's why you have to know how the stool progression is. Okay. All right, good. All right. So let's talk about skin of this little guy. All right. So we know about, these are things you've already probably been introduced to already, because I know we have. Tegumentary of the skin, and we have a baby with a lot of vernix caseosa. That's your cheese-like protective covering, right? It's an antimicrobial, microbial, and it prevents fluid loss. Okay, so that's your vernix caseosa. That's it looks like real good cold cream. You just want to have it lit now, right? Okay, and then you got acrocyanosis, which is your bluish discoloration of hands and feet. And acrocyanosis is normal within the first 24 hours. So write that down, because I know they like to put a question like that. Is the baby, they give you the baby is so many hours old, and then mommy and daddy are very worried about the baby's little coloring of his hands and feet. What would the nurse tell them? Okay, so that would be what? That's normal. Okay, then you got Mila, M-I-L-I-A, and those are like little pimples. Okay, so these are what they're sweat glands on the nose and an area, and sometimes they get over here. And what happens is the infants don't sweat for the first 24 hours. So these are like little sweat glands that they come up, right? And they look like little pimples. And a lot of mommies would go, my baby's got pimples. And then tell them, no, don't try to pop them. No, because that would be an open area for an infection. So that's normal, and they will go away. Okay, so write that down. Mila, M-I-L-I-A, white pinpoint papulars, and their sweat glands on the nose. Remember, infants don't sweat for the first 24 hours. Then you have the Nevi simplex, and these are like little orange or salmon patches. They're called like little stork bites. They're pink spots on the nape of the neck, like right in this area right here. They blanch easily, and they're 80% of newborns. So they have this little stork bite looks, things, pink spots. Now you have another thing called Mongolian spots. Now this is like a bluish black pigmentation, and you'll see it on the back and the buttocks of the baby, and is more common on like dark skin people of Latin America, Africa, Mediterranean. They look like a bruise. So this is where you got to be careful. They look like a bruise, and they document, be very careful, and they phase over time. Okay, so you have to be, when you see an infant come in, you've got to make sure, you investigate this, because you don't want to, it could be child abuse. So we want to make sure that we know the difference between a Mongolian spot and what's going on in the family. Okay, then you have a next one's called erythema toxum, Toxicum. And this is a newborn rash. So what happens, it appears in the first 24 hours, and it can last up to 3 weeks. So they have like red papulars, little small vessels, and there's no treatment required. Again, you got to tell mom it's okay. It's a newborn rash. It appeared in the first 24 hours and it can last up to 3 weeks. It will go away. No treatment. Okay. Moms get a little bit upset when they see things like that because they, they want their babies what? To be perfect. Okay. And then you have the last one is called Langugo, Lanugo, and those are little fine hairs on the body. And they often disappear during the first week of life. On a term baby, you may see very little, like maybe on the shoulders and on the ears still. There may be some little Langugo and in the back, the top part between the scapular, sometimes there's little hairs. On a pretermer, you would see more. On a post-term, you would see even less than a term baby. Okay, so those are all part of the integumentary system. So my question for you is this. All right, right after birth, when the skin of the baby's trunk is pink, but the soles of the feet and the palms of the hand are bluish, what is this called? I'm not even going to tell you the choices. You tell me, what did I just describe to you? Pam? Let me see. What did you write in the chat? Let me see here. That would be acrocyanosis, right?
Yes.
Okay. I told you they always like that term. Okay. All right. All right. So we're going to talk about the baby's head. Now, thank goodness little babies are able to go through what we call molding. So because we have a lot of soft tissue here, the suture line it's not completely together. It's there, but I mean, it's able to what? The shape of the head is able to mold, conformed to mom's pelvis. So that's good. But by doing that, he's got to come through the birth canal, right? We talked about this when we talked about labor. All right. So the head, remember too, the head is what? The largest portion of the body. So the circumference is measured from the top of the eyebrow to the widest part of the occiput. So the head circumference should be equal to and no more than 2 centimeters greater than the chest. So the head is bigger, right? Okay. Now we talked about molding, and that's conforming of the fetal head to the size and shape of the birth canal. So you have a long and cone-shaped head. That's normal. Because what? He's been in the birth canal. The longer they're in the birth canal, the more cone shaped they're going to be when they come out. Okay. All right. So then we have two other situations that can happen in the pelvis. You can get what we call a caput succedaneum, and you spell that as SUCCEDANEUM. All right. So what is that? Well, that's swelling. It's just fluid swelling over the scalp. And you can see that I'm pointing on my head. You can see that it does cross the suture line. Okay, so write that down. That caput succedaneum, it crosses the suture line because here's the sutures. And in your book, you can see the diagram of the head, and it crosses the sutures. Okay, now that does disappear in 3 to 4 days. So moms, they go, "What's my baby? What? No, it looks like a cone shape, right?" And so you'll be all right. And another description, it could be, it looks like a cat. Okay, so again, they'll go down. Now the other one that can occur, maybe during a tough delivery or a forceps delivery, is a cepha hematoma. So that's spelled CEPHALO hematoma, HEMATOMA. And what is that? That's a collection of blood. Now this one here does not cross the suture line. The caput succedaneum crosses the suture line. We talked about that. It's right in the middle, right there. Okay, this one is more on the side of the head. So look at my head. It's more on the side of the head. So that one does not cross the suture line, because here's your suture line in the middle, right? And this one is on the side of the head. That's the easiest way to remember this. So it does not cross the suture line, and it does get reabsorbed. What happens, you have some hemolysis that may be occurring, and that baby's body will reabsorb that blood. Now that takes about 2 to 8 weeks to really resolve, okay? All right, so what do you have to worry about cephalhematoma is increase in the amount of bilirubin, because the baby's liver may not be able to break down the extra bilirubin, so he becomes what? Jaundice. So that you have to be careful of. Okay, and then you have fontanelles, and we talked about that, depressed, and that's associated with dehydration. And the bulging fontanelles are associated with increased cranial pressure. So in your book, it shows you how to measure the baby's head, and it goes over that. It goes over the suture lines, and on the PowerPoint too, it goes over that. All right, any questions on the head? Any questions, Pam? Are you okay with the head?
Yes.
Yeah, okay, everybody good? All right, just want to make sure that you're all good. Okay, so how about a question? You ready? All right. So on a newborn's head, the nurse notes a swelling of the scalp that does not cross the suture line. What is her finding? Is it molding? Is it cephalhematoma, a caput succedaneum, or a enlarged fontanelle?
2.
D.
2. Yes, 2. Good. Now, what gave it away was that it was a swelling of the scalp that does not cross the suture line. See how I was adamant about where it occurs and how it does not cross the suture line?
Yeah.
All right, that's one way. They always like this question. So does Hesse, by the way. All right. How about another question? You ready for another one? What is the nurse's best response to a mother who's voicing concern about the molding of her 2-day-old infant? I told you, this is always a good question. So so the question's asking, what's the best response? Okay, so molding doesn't cause any problems. Don't worry about it. A traumatic delivery can cause molding. Ah, you're telling this to mom. Did you deliver vaginally or by cesarean section? Or the baby's head formed the shape of the birth canal. It will go away. Which one would you say? What's the best response to this mother?
D.
D. Right. Dorina, do you agree with that?
I agree, yeah.
The baby's head, Pam said D. The baby's head forms the shape of the birth canal. It will go away. That's the best response by the nurse to a mom who's voicing concern about the molding of her 2-day-old infant. So, would you agree with that?
Yes.
Yeah, I do too. You're absolutely. Okay, so the next topic that I really want to stress is respiratory distress. Okay, and what's the signs of respiratory distress? Remember I told you, I think it was last week when we did term newborn, I said, know the normal vital signs of the infant, right? Okay, so I hope that you wrote that down. So signs of respiratory distress are, if you have respiratory rate less than 30 or greater than 60. Okay. You have bradycardia. The heart rate is less than 110. You have nasal flaring. That means his little nostrils are flaring up, outward. They're flaring up. Stridor or grasping. Those are signs of what? Obstruction. Okay. Grunting with respirations. You see his little intercostal or subcostal retractions. His whole chest is going up and down. You see, and what you see Yes, I'll tell you what you see the xiphoid process actually what go down. Okay, that's how he's working those ribs and all that's retracting. Because why? He's trying to breathe and I can't breathe, nurse. Okay, then you have substernal or subclavian retractions. Hypotonia, that means what? He's losing tone. And then you have central cyanosis. Central cyanosis. Now we talked about acrocyanosis being normal. Yes, but when you have central cyanosis, that means the trunk of the body now is what? Blue. Okay. Then you have tachypnea, and that can be a sign of inadequate fluid clearance, respiratory distress syndrome, cardiac respiratory illness, or meconium aspiration syndrome. Now we talked about meconium aspiration syndrome, and that's never good because that means the baby he aspirated on his own meconium when he was born. So that's why we, if meconium stain fluid is noted in labor, we assess respiratory status right at birth, right? So we suction him as the head comes out. We'll suction before he takes his breath, right? And then the baby then is delivered. We don't stimulate him to breathe. Oh, no, no, no. We take him over, and respiratory therapy and the NICU nurse are there, and the respiratory therapist can put a tube down and really suction nice and deep and get that out. Okay. So we don't want the baby to aspirate on meconium because he can get into hyaline membrane disease, respiratory distress. All right, so let's think of the mnemonic wet frog. So write down W-E and a T. So write down wet, W-E-T, and then write down frog, F-R-O-G. This is going to be a mnemonic that you can learn for signs of respiratory distress. So W would be for wheezing. So what that sounds like is a high pitch in his airway. And then E is for effort. That's the inward movement of the the clavicle and the fossa, all they move inward. So it's E for effort. I'm trying to breathe. Tachypnea is greater than 60 breaths per minute. Then you got, for the F, you got flaring. That's nasal flaring. And R is retractions. We talked about that. O is for oxygenation. What's the color of this baby? Is he pale, central cyanotic? What's his mucous membranes look like? And then grunting. These are sounds that you hear, and it's very obvious when they're grunting. So grunting with respirations. These are signs of respiratory distress. And I think it could be a really good all that above, you know, one of those famous questions that you love, all that above. Okay. So here's a question for you. So what symptoms assessed in the newborn shortly after delivery should be reported? All right. Okay. So again, I asked myself, what's the question asking me? So the question's asking me what symptom assessed in the newborn shortly after delivery should be reported. A is cyanosis of the hands and feet. Well, that sounds like actual cyanosis, so that's normal. Irregular heart rate, or sternal or chest retractions, or mucus drainage from the nose. Which one should be reported?
C.
C, absolutely. That's a sign of respiratory distress in that newborn. Absolutely. Okay. All right. The next area we're going to review for the test is on genitourinary urinary. Okay, so what we're going to do is write this down. We have to always note the first void of the baby. Very important. So you notify if the first void does not occur within the first 24 hours. And newborns should have how many wet diapers per day? 6 to 8. 6 to 8. All right. Now, there's certain parts of the male genitalia that you have to be looking out for, and that's your undescended testicles, or the torsion, which is your bluish discoloration of the scrotum, or the hydrocele, which that means that's accumulation of fluid around the testes. And you can see that actually it transluminates with light. Now, if the male is going to get circumcised, what that is a surgical removal of what? His foreskin. And, you know, to children that do get circumcised, they have fewer like UTIs and STIs. And, you know, they can't get a circumcision if they have like hydrospadias or epispadias. They can't get circumcised. They have to correct that first. And then consent, you always get a consent form, and you always think of newborn pain. Remember, they do feel pain. And you always have a bubble syringe, and you make sure that they don't get cold stress. So I always have like a heat source nearby, you know, over the baby. Keep the baby warm. Because look, you know, in the picture in the book too, it has that baby, he's all what? He's all kind of strapped down and to a board. And that looks terrible, but you know, it does prevent him from, he would be moving around and trying to help the surgeon. So you don't want that to happen. You want a nice clean cut of the foreskin. Okay. So you want to record his voiding afterwards, and you observe for bleeding, infection, and any kind of irritation. So you want to always make sure that after circumcision, he's voiding. Okay. All right. Now, the female genitalia, it could be that it's a little swollen, and it may have a slightly bloody vaginal discharge. And guys, that's okay, because don't forget, she got the hormones from mom. And so we call that what? Pseudo menstruation. So, and you teach mom how to clean from the urethra to the anus. Okay, so I would know about circumcision. I would know about what I need to have. It's always good, you know, to go over that. And I just went over that with you. You know, you always get a consent form. Okay. And then know that the baby could have pain. So sometimes they'll do like a local administration. And then baby can get himself so upset that he can start choking. So you want to have a bowl syringe and make sure that he's not cold. Yeah. Okay. All right. So while we're on the talking about circumcision, let's talk about neonatal pain. So they do go through some pain, and we know that. And there's description, and we went over this just the other day, last week, about the different pain scales between the NIPS, the PIP, the NPAS, and the cries. So just go over that again so you have a good idea of what we look at. Okay. And then and just know that they go through the same thing. The neonatal responses to pain, psychological and physiological, their heart rate changes, their respiratory rate goes up, O2 sats, intracranial pressure even in their head. They get so upset. The little brow gets what we call furrowed. They get a clenched fist. Their chin, the chin starts to quiver. Oh, you feel so bad. And then you have facial grimace. And the very common sign is vocalization or crying. They cry really hard. They make themselves so tired by doing this, but they're letting you know that they're in pain. Okay, and the best one I like of the pain assessment scale is called the cries. All right, now, how are you going to manage this neonatal pain? Well, you want to minimize the intensity or duration. So there's like circumcision, get it done, get it done and over with quick, okay? So you get the baby prepared and sometimes we give them a little pacifier as we're waiting for the doctor, and the doctor comes in, applies a little lidocaine gel and does the circumcision. And then maximize the ability to cope with and recover. And so, after you get done and you cut the little gauze and everything, you wrap them up, swaddling, wrap them up and put his hand near his mouth, or, and maybe give him a little pacifier, kangaroo care, and, a little distraction, a massage, and always, to mom. Give him to mom. He wants his mommy. He wants to know everything's okay. So that is the pain of the newborn. So now we're going to go to preterm birth, because this will be on exam number 3 also. And here it is. Complication of preterm birth. The first one is respiratory distress syndrome. Remember, I always said that biggest job of this little baby is to what? To breathe. And because they're newborns, they don't have the amount of surfactant in their lungs that they need. Okay, surfactant, write that term down, surfactant. All right. So on a pretermer, if we can hold mom off enough, we can give her what? 2 doses of betamethasone, the glucose steroid, to increase the production of surfactant in the newborn's lungs. Okay, so that's why I said we get that in so that we're helping this newborn what? To breathe. Okay, and so this respiratory distress syndrome is quite serious. It used to be known as hyaline membrane disease. I think I even said that. That's an old term. And is responsible for more infant deaths than any other disease. Okay. And almost exclusively in preterm infants, and it's twice as likely in males. And I tell you, I hate to say it, but little boys, little males, pretermers, they are lazy. And so there's a lot we have to do with them to get them going. I talked about surfactant deficiency already. And basically it's just they don't have enough in their alveoli. Remember, I talked about that already. And it causes respiratory distress. Now, infants are unable to keep lungs inflated without that surfactant. So they need that surfactant. And I tell you, we give mom the betamethasone, we deliver this baby, baby goes to NICU, and in NICU, they can give them surfactant in elixir, like a liquid form, and that can be administered right through the ET tube, and they do that. Why? Because they don't want this baby to be overworking itself to breathe. Okay, they're trying to help this baby, because when a baby uses everything he has to breathe, then he's replenishing a lot of other things like his glucose. He can become hypoglycemia related to that. So that's why we want to make sure that they can breathe. Another reason. Okay, so you may give that baby some oxygen therapy. And so you may give it through the baby will be intubated, so it has an endotracheal tube. And you may have them on some CPAP, which is your continuous positive airway pressure. And then write this down. Oxygenation saturation should be 92% or greater. Okay, so I'm going to repeat that. Oxygen saturation should be 92% or greater. So I hope you wrote that down. And then clinical manifestations. That means what? What am I going to see in the clinical realm? I'm going to see tachypnea. That means what? Greater than 60 breaths per minute. And I'm going to see those retractions. Remember, we talked about those intercostal and subcostal retractions. And then you have crackles. When the baby tries to take a breath, inspiratory crackles. You're going to hear crackles. And then you have expiratory grunt. He's grunting. Remember, that's all part of respiratory distress. Nasal flaring. The baby's little nose will go up, just like it would. And cyanosis or paler. Now, what are you going to do? The pulse oximetry. And on page 316, and that's skill 13.1, is how you apply a pulse oximeter to a newborn. And then you got bulb suctioning. And then that's on page 291, skill 12.2. We talked about that, how you depress the bulb and insert it into the side of the mouth. Because why? I don't want to go right in the middle, because if I do, I'm going to start him to have the gag reflex. So side of the mouth. Okay. So those are complications of preterm birth. All right. Any questions on that? All righty. Now, what are some associated complications for a little guy? And I hope you can see, I sent the PowerPoints out and see on the PowerPoints, the pictures. And also I did send you, under announcements, it's been a while, it was on a preterm birth. And that was the story of Griffin at 26 weeks. And it shows you how tiny they are and how they have to grow. And so these associated complications, hopefully we don't want them, but it can happen. They can get a pneumothorax. The next big one is called bronchial pulmonary dysplasia. And I will write that down. So that's bronchial pulmonary dysplasia. So I'll spell it as BRONCHOPULPONARY, dysplasia. And what that is a chronic lung disease. Is due to mechanical ventilation and long-term use of oxygen. Now, years ago, I'm going to tell you, years ago, over about 30 years ago, we used to give all these babies like high doses of oxygen. Okay, you know, the more the merrier, right? No, you can have a toxic response in the lungs, and that's where you get this bronchial pulmonary dysplasia. Okay, and that's because oxygen has been used for way too long at too high of a level. That's why we have pulse oximetry. That has helped us quite a bit, because then we can tell if he has enough oxygen. And remember, he's oxygenating 92% or greater. Okay, then you have neonatal hypoxia. Another complication that can happen to a little preterm. And then you can have apnea of prematurity, where he just, you know, doesn't breathe. And so we treat it in the ICU with caffeine. And then a lot of these babies will go home on an apnea monitor, where they put this little monitor around the baby's chest. And when the baby has little apnea episodes, it sends a little, it kicks the baby. It kind of like gives a little jolt and makes the baby to breathe again. And plus has a little alarm on it. And then you can have retinopathy of the premature due to oxygen, where the retina is now the vessels in the retina get injured. And so you see a lot of little premature babies that grow up, they have what glasses on, is because they had too much oxygen. And again, it's a result of high arterial blood O2 level. So, you know, you can't, you know, overdo, because when you overdo something, now you're creating another problem somewhere else. So again, you know, vital signs, pulse oximetry, knowing, you know, the level, oxygen level in the hemoglobin is important, so that you don't over oxygenate, because two things, the retinopathy, and that's spelled RETINOPATHY, and bronchial pulmonary dysplasia are two that be caused by what? Too much oxygen. Okay, so everybody got that? Okay, we're almost finished, so hang in there with me, guys. So another complications more on preterm birth let me go through the list. So write this down. Sepsis. Okay, and we went over the signs and symptoms of sepsis, such as temperature instability, poor feeders, and respiratory distress. So write down sepsis, and under sepsis, your signs and symptoms of temperature instability. You have poor feeding and respiratory distress. And a lot of times with babies, if they don't feed right, that's like a big sign. You know what I mean? A big sign. And then of course you have respiratory distress, and then of course temperature instability. So that's not good. Now cold stress. I talked about cold stress quite a bit, and what happens is that they're cold. So what's going to happen? They're going to use up all their glucose, so they get hypoglycemic. Okay, because don't forget, babies don't have a lot of brown fat. So especially the premature ones. So they lose a lot of heat, and they get cold stress very easily because they just don't have the brown fat that you need. So you can get hypothermia related to less brown fat. Okay. And so in the brain too is, you have your heat center in the brain, and on babies, their little heat center is immature. So you have to be, you're the one responsible for this baby. You have to keep it warm. Okay. And remember, babies don't shiver. And so they kind of lay there, and they're using up all their glucose. So now they're getting hypoglycemic, and they're getting tachypnea because they're trying to get warm. And because of all that, they get what? They get tired. Heck yeah. And then their heart rate will go down. They'll get bradycardia, and they have decreased skin temperature. And they have what we call mottling, MOTTLING. Now that sounds like a good all that apply question. So I definitely would know cold stress and what happens. So we're going to go over that again. Signs and symptoms: tachypnea, okay, being lethargic, bradycardia, decreased skin temperature, and mottling, MOTTLING. Okay, now we talked about a little bit of hypoglycemia because of the less brown fat. Your signs and symptoms of this would be a weak cry. You have little tremors. And you can call that jitteriness. You got convulsions even, which is pretty bad. That means your glucose must be really low. And then the lethargic. Now for a term baby, is a glucose less than 40 milligrams per deciliter. So according to what book you read, some books say 45, some other books say 40, but that's on a term baby. And then for a preterm baby, you would have 30 milligrams per deciliter. So the question may show you that the baby has is a preemie. Maybe the scenario is a premature baby, and the baby has like 28 milligrams. So what would the condition be? And that would be hypoglycemia. Okay, and then you have another complication could happen is hyperbilirubinemia. That's a big old word, but all it means is increased bilirubin in the blood. All right, and then jaundice. Okay, so pathological jaundice occurs in the first 24 hours of life, and physiological jaundice occurs about day 3, 2 to 3. Okay, that's a normal jaundice where the liver, baby's liver, just can't break down the excess bilirubin, and therefore then doesn't get unconjugated, so therefore it gets dispersed in the baby's body, and it becomes what? Yellow. All right, and then you have another complication, necrotizing enterocolitis, and I'm going to abbreviate that by doing NEC. And what that is an inflammatory disease of the GI mucosa, and it's most common in preterm infants. And your signs and symptoms would include maybe, we think about it. Okay, it's inflammatory disease of the GI system. So, in the mucosa, the lining. So what happens is you have abdominal distension. Their bodies, their little abdomens become what we call real shiny looking because of the increased distension. The skin is getting what? Stretched. And then you have temperature instability. And then his little stools have blood in them. So that gives you a good hint that something's going on in that GI mucosa. So breastfeeding has the greatest effect on for lowering the risk of it, which is great. Okay. Now, when you're taking blood from the baby and you're doing a heel stick, be sure that you don't go in the middle of the foot. You're going on the side of the foot. Okay. When you do like your test for PKU or any of those or hypoglycemic, you want to make sure that you go on the side of the foot. You don't want to go right to the middle because that's where the nerves are. Okay, so how about a question? Ready? All right. So 1 hour following a normal vaginal delivery, a newborn's infant boy auxiliary temperature is 96. His lower lip is shaking. And when the nurse assesses for a Moro reflex, the boy's hands shake. So which intervention should the nurse implement first? Okay, so would she stimulate the newborn to cry? Would she obtain a serum blood glucose? Would she feed the infant formula, or would she wrap the infant in warm blankets? What do you think the correct answer with this is? So what's the question asking me? So I got this, I had a normal vaginal delivery. I got a newborn. His temperature is low, it's 96, right? His lower lip is shaking. And when the nurse assesses for a Moro reflex, his little hands just shake. What do you think I should be looking for? What is he demonstrating signs of?
The baby needs to provide warmth.
Well,
You need to provide warmth to the baby.
well, you think that, but okay, so the question is, his lower lip is shaking, so he's quivering. When the nurse assesses for the Moro, he kind of shakes. I can see why you would say that, but what would be the better answer? What should I implement first? What am I thinking? Okay, what I'm thinking is he's quivering, right? So he could be a little cold stress due to a low body temperature. But what's causing it? What's the first thing causing it? So what should I find out? What did he use a lot of? Trying to keep warm. He's using a lot of what? His sugar level. So I would want to know.
Oh,
what
sugar.
his
Oh, yeah.
blood glucose. Yeah.
Oh, blood glucose, yeah.
Yeah. Well, see, this is good. This is a great way of talking this out. So yeah. So what I would do, he's demonstrating signs of hypoglycemia. Yeah. And so I do a little blood test on him, see what he's up to, and then what do? I may, put a nice warm blanket around it because it's possibly this hypoglycemia is possibly secondary to a low body temperature. So I got to know both, right? I mean, so I want to know what that blood glucose level is because then he could get worse if it's real low, don't you think? Yeah, he could. Okay, so everybody in agreement with that? Pam, are you in agreement with that? Okay, good. So nursing goals for the preterm newborn. Okay, so on page 319, box 13.1, we talked about this last week on these newborns, thermoregulation. That's why we put them under radium warmers when they're born, and they can, and especially with a preterm newborn, we use the incubator, and you will see that in these NICUs. Kangaroo care is another one too, that mom comes in Poles baby, and we put kangaroos skin to skin. Like the little kangaroos, like the, you know, the babies in the little mom's pouches are so cute. That's where that term came from, skin to skin. That it is helpful for the premature baby. And then nutrition. Okay, so babies don't, maybe pretermers don't have that what, sucking reflex. So we have to use some gavage feedings. And basically, it's the little tube that goes down into the stomach, and we can feed the babies that way. We have to be careful about aspiration, and of course, we can get a lot of meconium that way too, but gavage feedings. And then positioning, decrease respiratory effort and promote drainage of secretions by different positions. Yeah. And change frequently to avoid skin breakdown. Absolutely. Newborns have a tendency to break down, have sores if they're not changed. The same thing is the skin. It's very similar to a geriatric patient. As you get up there and way up there in age, the skin is easily gets break down, and it's thinner. So positioning the baby is important. Okay, so that was about pretermers. So what we got one more at the area is called post-term infants. All right. Remember that after every chapter, you got your unfolding case study. So I want you to make sure you read that. Now, post-term infants. So what terminates a post-term infant is an infant that extends beyond 42 weeks. Because you have your pretermers from viability to what, up to 37. Then you have your term babies from 37 up to 40, 41 weeks, and post-term is beyond 42. That's really going barely beyond. Okay, what happens to these post-term babies is that they're in there and they're just getting fatter. Once they go past their 40 weeks, it's time to what? To get evicted, to get out. But if they're in there longer, what happens is that they can have their increased risk of birth injuries. And that's related to macrosomia, large babies, CPD, cephalopelvic disproportion. All those babies can have, they're more at risk for birth injuries. And then you have placenta dysfunctioning. It's very common, right? I went over that as to say, at 40 weeks, the placenta now says, hey, I'm supposed to be done. And it starts to get calcified. And so it does not put out the nutrients and the oxygens baby needs. And then you run into a really big problem with post-termers is that they have meconium stained fluid. Now, meconium stained fluid can lead to what? Meconium aspiration syndrome. And that's called MAS. Meconium aspiration syndrome. And then you have significant increase in fetal and neonatal mortality. Yeah, and I told you about my patient that was a VBAC. She didn't want to have a C-section, but she had to go into spontaneous labor because we can't induce a VBAC. So she was a high-risk patient also because of her age. So she was an advanced maternal age patient. And so we were doing non-stress tests on her, and we were doing them twice a week to ensure that the baby was doing okay. But she got past about 42 weeks and maybe a little bit longer. And I said to her, I said, well, it's really time for me to really book you for a C-section. We need to get this baby out now. Baby's still okay, but we need to get him out. And so this was like on a Friday. And I said, it's time. So how about this weekend? So I called the hospital and booked her for a C-section on Saturday. And of course, anesthesia doesn't like you too much to book an elective C-section on a weekend, but we did it. And so I gave her all the instruction, and she was like, no, I don't really want this. And she was giving us a hard time. And I had my chief of OB in there because I wanted to have an ample amount of witnesses to the conversation. So she didn't show up for the C-section on Saturday. And Sunday night, she presents herself to the labor unit, and she says she hasn't felt the baby move. So they put her on the monitor, and there was no fetal heart tones. The baby had passed. And so when I came in on Monday, they brought me into the office to tell me, because I had known this lady and, got to know her quite a bit. And because I was doing a lot of NSTs on her, and baby had passed. So what happens is that, again, the placenta gets old, doesn't give the oxygen nutrients to the baby like it should. There's more chance of a cord accident. Baby gets big. And so there's decreased room as it is. Fluid actually goes down. She gets more of what we call oleohydramnios. And so therefore, baby passes. This really does happen. That's why I'm sharing the story with you on a post-term baby. Now, another problem you have with a post-term baby is you have the skin. The skin is cracked and it starts peeling, and it's very, very dry. And you know that anytime you have any kind of interruption in the skin, it's hard. You have to keep lubricated, because you can get infections easier too. And then, of course, with post-term babies, they can have what we call fetal distress and maybe get asphyxiated. And so they have more problems at birth. And then you have problems with a big baby. It's called hypoglycemia, low blood sugar in this baby. So post-term babies have to be watched. No, most of the time what we do when we get somebody that goes beyond 40 weeks, they get what we call non-stress tests, where you have to have 2 fetal movements with an increase of 15 beats above baseline lasting 15 seconds. Okay. All righty. So that's hypoglycemia. So how about if I give you a question? Okay. So using the Ballard gestational age assessment tool, the nurse determines that a 15-minute-old infant has a gestational age of 42 weeks. Okay. And based on this finding, which intervention is most important for the nurse to implement? Okay. So we know this baby now is 42 weeks. So should we obtain a capillary blood glucose? Should we draw an arterial blood gas? Should we provide blow-by oxygen? Or should we apply a pulse oximeter to the foot? Okay, so the baby's 15 minutes old, guys. So his gestational age of 42 weeks. So based on this finding, which intervention is most important for the nurse to implement? So if you chose A, you were correct. Obtain a capillary blood glucose. What do we worry about? We'll worry about hypoglycemia. All righty, hang in there. I got a couple more slides. This is on hydrocephalus. And we're probably, if you're in my class tomorrow, you'll get this tomorrow also. But hydrocephalus is a large head. It grows fast. So it's a large, rapidly growing head, and is due to the improper balance of the production and absorption of cerebral spinal fluid. So the picture here shows you very good about what a normal head looks like and what a baby who has increase of cerebral spinal fluid. So you can see that. See all that? See how bulging it is? Well, see the picture, because of that, how that all that fluid in the head becomes much larger. And so what happens that these babies have to have shunts put in. And so you have, so preoperatively, this is what you have to remember. Preoperatively, you have frequent head position changes to prevent skin breakdown. Yeah, because just imagine the head is so big on these babies, and the head has to be supported at all times. That's a really good test question. Head must be supported at all times. And you measure the head circumference along with all the other vital signs when you have a baby with hydrocephalus. Because why? Because you want to see if the baby's head has increased since the last time you did the vital signs. Now, post-operatively, you're going to assess for signs of increased intracranial pressure post-operatively, and you're going to protect him or her from an infection. Because don't forget, they just had surgery to put this shunt in. And what they do is they put it in the ventricles, And what happens, it comes down from the ventricle, comes below the ear, and it goes down into the stomach. That's where it goes. So positioning of this kind of baby is very important because you want to promote drainage from the ventricles. So I'm going to put this baby in a semi-Fowler's position. So I would kind of remember that, write that down. These kind of babies, you want to promote drainage from the ventricles through the shunt. Okay, so you want to put them in semi-Fowler's. You also, of course, I mean, they just had surgery, so you want to assess and provide for pain control and teaching. Signs and symptoms, headache, lethargic, changes in level of consciousness, you need to teach mom. Okay, so that's a hydrocephalus baby. As you can see, the large head, and it's rapidly growing, and it's because it's just improper balance of production and absorption of the cerebral spinal fluid. Okay, the next problem we have is Down syndrome. Now we know Down syndrome is most commonly chromosomal abnormality. Okay, so it can be diagnosed with an amniocentesis. So write that down. You might see it again. It can be diagnosed with an amniocentesis because an amniocentesis is a chromosomal analysis of fetal cells. So who's at risk? The risk increases with mom's age. So 35 years, mom's at advanced maternal age, and father's 55 years and older. Those chromosomes start to what? To change. So they get into a high risk category. So with Down syndrome, they can have a mild to severe mental retardation. They do have some physical abnormalities. And this is what manifestations they present. They present closed set eyes. They have a protruding tongue. They have those creases called a simian crease, and the crease goes straight across the hand. The hands actually are short and they're thick, and their little fingers sometimes are curved. The toes, they have a wide space between the first and second toe, and their growth and development is at a slower pace, and they're limited intelligence. And sometimes, unfortunately, they get some congenital heart deformities. Now, these kind of children are poorly resistant to infection, and they're prone to respiratory and ear infections. Also prone to speech and hearing problems. So again, that's Down syndrome. So I would definitely know the manifestations of what they would present with. And again, there's closed set eyes. The protruding tongue is the big one. I've seen that a lot. And then of course the simian creases. You see that a lot. Okay. So let's see, we've got another question for you. So which of the following assessment findings would lead the nurse to suspect Down syndrome in an infant? Would it be a small tongue? Would it be a transverse palmar crease? Would it be a large nose, or D, restricted joint movement? What do you think, guys? Pam, what do you got?
Can you repeat the question again?
Okay, sure. So what's the question asking me? Which of the following assessment findings would lead the nurse to suspect Down syndrome in an infant? Would it be a small tongue? Would it be a transverse palmar crease? Remember I told you about the crease?
Yeah.
Yeah. A large nose or restricted joint movement?
B.
B, absolutely. Okay, so that's why I told you to know those manifestations. So you may have to go back over that. Okay, so we got one more, I believe, getting to the end here, cleft lip and cleft palate. So what happens with that is it doesn't close during the developmental stage. And so now you have this little fissure. So this lip and palate is characterized by a fissure or opening in the upper lip. And many cases are hereditary. Some are environmental, and some So what are these? Hold on just a moment. Okay, you guys okay? All right. Okay, and so you, let me just see what's going on. Hold on, guys. Let me just pause for a minute. Oh. Okay, so what I want you to get out of this with the cleft lip and cleft palate is that they're increased risk of a middle ear infection. So write that down. They are increased risk of a middle ear infection. All right. So, and this is what we check too. When the babies are born, we have our glove on and we just check to see the palate to make sure that it closed. Because what it is a fissure or opening in the upper lip or on the palate. All right, so the treatment. So you want to repair this by 3 months of age. And the infants may have to have like some elbow restraints to prevent the infant from scratching the lip. Because when you have a cleft lip, you want to have a really good surgeon. And usually it's a really good plastic surgeon that does this. But the aftercare is harder because the baby wants to scratch the lip. So that's what happens. And then you get an infection in there and it doesn't look good at all. And then the child, grows up having this big old scar. And you don't want that. You want it to be come together nicely. So this is another important concept to remember. A special syringe or bottle may be needed to assist in feeding. So a special syringe or bottle may be needed to assist in feeding. And then you want to ensure adequate nutrition. So put a circle around that. Ensure adequate nutrition. That's a big problem because some of these babies don't eat very well. And you can see why. All right, so question. While assessing a newborn with a cleft lip, the nurse would be alert that which of the following most likely be compromised? Would you think it would be sucking ability, respiratory status, locomotion, or GI function? This baby has a cleft lip. Which of the following would be most likely to be compromised? What do you think? A, sucking ability. Absolutely. Sucking ability. Because of the defect, the child will be unable to form the mouth adequately around the nipple. Sure. Thereby requiring special devices to allow for feeding and sucking gratification. Okay. All right, let's see, we have another question. When assessing a child with a cleft palate now, the nurse is aware that the child is at risk for more frequent episodes of otitis media, which is an ear infection, due to which of the following? Now, this is a good question. This is always, I've seen this a lot. So A would be lower resistance from malnutrition. B, ineffective functioning of the eustachian tubes. C, plugging of the eustachian tubes with food particles. Or D is associated congenital defects of the middle ear. Now, what's the question asking me? The child has a cleft palate. So the nurse is aware that the child is at risk for more frequent episodes of an ear infection due to which of the following? What do you think it is? I'm going to let you write this down. It is B, ineffective functioning of the eustachian tubes. Then let me tell you why. Because of the structural defect, children with cleft palate may have ineffective functioning of their eustachian tubes. That's why they have frequent bouts of an ear infection or otitis media. Okay. Now, granted, option A, lower resistance from malnutrition, most children with a cleft palate remain well nourished and maintain adequate nutrition through the use of proper feeding techniques. So you would think, well, maybe malnutrition, but no, they're not nourished because we do have special feeding techniques. What they get the ear infection, that's what the question's asking me, right? They get the ear infection because of ineffective functioning of the eustachian tubes. Do y'all see the difference? Okay.
Yes.
Okay, good. All right, so we got a couple more defects and then I think we'll be finished. So y'all hang in there. So we're gonna talk about jaundice. So we know what jaundice is about the bilirubin and how it gets synthesized, it gets broken down in the stool, feces. When they feed every 2 to 3 hours, they get rid of the extra bilirubin through their stool. Okay, so jaundice, if you want to refer to page 300, skill 12.4, is that they have unconjuncted jaundice, phototherapy. Now, so physiological is destruction of SS red blood cells, like on 2 to 3 days of life to 1 week. So remember I told you about the red blood cells are breaking down and they can't keep up with the excess bilirubin. So the skin appears to be yellow. And then you have the non-physiological or the hematological disease, which is for your liver disease, and that's erythroblastosis fetalis. And then you have acute bilirubin encephalopathy, which is acute manifestations of toxicity. So what happens on these kind of babies? You have hypertonia, you have a seizure. It's really bad. Lethargic, coma, and death. Now, kernicterus is spelled Kernicterus. That's irreversible, and that's hypertonia, and that can actually affect the brain and delay motor skills. And we'll probably discuss this a little more tomorrow. But again, jaundice. So let's have a question. So a 1-week-old full-term infant is readmitted to the newborn nursery for hyperbilirubinemia. What supplies should the nurse gather in preparation for the infant's treatment plan? Okay, so we are going to what? We're going to do phototherapy on this baby, right? The ultraviolet light. Okay, so he's readmitted. Well, he went home and his jaundice increased. So now he's readmitted to the newborn nursery. And his diagnosis is hyperbilirubinemia, excess amount of bilirubin in his blood. Okay, so I'm going to gather up my supplies because he's going to have phototherapy. Okay, so would I gather up an eye shield, patches, and an artificial light source for phototherapy? Would I gather a butterfly needle and a 3 ml syringe to obtain arterial blood gas? C, a scale to weigh diapers and a flow sheet to record urinary output? Or D, an oral gastric tube and a 30 ml syringe for gastric feedings? Which of those is the correct answer? I'm going to do phototherapy on this baby, right? So I have to protect the baby's eyes. So I'm going to get an eye shield, patches, and artificial light source for phototherapy. Okay, so remember we put him under phototherapy, and we have him naked under phototherapy. He's in like an incubator. We have the light ultraviolet on him. He only has like a little diaper for his secretions, and he's going to get intense ultraviolet light that will break down the excess bilirubin, and what happens is that he will excrete it in the feces. So that would be A. Okay, we got to protect the eyes because it's just like you going to the beach and sitting on the beach, and you have the sun coming down on you, the ultraviolet light from the sun, that could hurt your eyes. So that's why you would wear sunglasses. So these babies, we put these eye shield patches on. Okay, and then this just goes over hip dysplasia and club foot. And what you want to know about hip dysplasia, you can see the diagrams, is that it applies to various degrees, subluxation or dislocation. So what happens is the head of the femur is partly or completely displaced. So 7 times more common in girls. And then we'll go over the Barlow and Ortolani test. And then you have treatments. Okay. And you can see on the little diagram, and it's in your book on the test where you can see the gluteal folds on one compared to the other. Now, treatment. The hips are maintained in constant flexion and abduction for 4 to 8 weeks. That's ab, as ABDUCTION, for 4 to 8 weeks. It keeps the head of the femur within the hip socket. So surgical intervention may be necessary. So that is on hip dysplasia. And then you have the other ones called club foot. And club foot is the most common deformity you'll see. What happens, the foot twists inward or outward. So inward or outward. And they're born with the child walks on his toes and the outer borders of his feet. So what's your treatment? Well, you're going to be splinting or casting and stretching. And then you have educate parents to assess skin breakdown, maybe cast care, and provide emotional support. It's an ongoing process. It may take several surgeries to get this better. So it's not easy for moms to see their babies with this kind of difficulty and see them in a cast, because it's hard to have babies in casts. All righty. And then we're going to go right into nursing care for spina bifida. Okay, so spina bifida is like, you can see there's a part of the meningocele is outside the spine. And what you have to be really, really careful about on this kind of baby is the prevention of infection or injury. So if there is a meningeal seal, you have to immediately place a moist sterile dressing of saline after delivery to prevent drying of the sac. I would write that down. So if you see here, you have a meningeal seal, you have to immediately place a moist sterile dressing of saline after delivery. Why? Because I want to prevent the sac from getting dried out. It's a living cell, but now we're outside, we're born. And so now that's outside the body. So the air is going to dry it out quickly. That's why you put that sterile dressing on it very quickly. I want to make sure I keep the baby in a good position to prevent pressure on the sac, And then skin care, you want to ensure this baby has good parent-infant bonding. And, you know, moms will just have to be shown how to handle the baby. And then a lot of times they have to do surgical closure on this, on the spina bifidas. All right. Yes, that's really quick on that. And then we're going to go into metabolic defects. So what happens here, you have the errors. There's something to do, there's the metabolism. There's an error in the metabolism. So it involves a genetic defect that may not be apparent until after birth. Okay, you can't see them ultrasound. So you have signs and symptoms. They're lethargic, they're poor feeders. As you can see, with these kind of babies, poor feeding. They also have low tone, hypotonia, unique odor of body or urine, tachypnea and vomiting. Like maple syrup comes to mind, the maple syrup urine disease. This is pretty serious. This can cause acidosis and it can cause death. And what you pick up, it is a sweet smelling aroma. And so you want to, if something is sweet smelling aroma, the blood glucose could be normal, but the urine smells too sweet. And that's why they call it the maple syrup urine disease. And the treatment is hydration and dialysis. And of course, infection can be life-threatening to this kind of baby. Yeah, that's called maple syrup. Again, these are defects in the metabolism. So you couldn't see these things, again, you couldn't see that on an ultrasound. That's why these are genetic disorders that are not apparent until after the baby's born. Another one is PKU, and that's when the body cannot break down the phenolphthalein. And so what happens, they get an increase in the brain, and it can cause mental retardation. So every baby gets a PKU test, and it's a lifelong disease, and they can't have anything with protein in it because they can't break down the phenolphthalein. So you have to teach parents how to read food labels, and they have blood tests, and you have to consult a dietitian because again, it's lifelong. And they can't be breastfed, and they have to have a special formula called lofenilec. Okay. And then you have glycosemia, that's GALACTOSEMIA, and that is unable to use the galactose and lactose. So what happens is that they could have a liver problem, maybe cirrhosis of the liver. Liver it's not there, it's not good. Cataracts, and they got mental retardation. So these kind of children cannot have any dairy. There's no breastfeeding, and you have to use lactose-free formula or soy protein-based formula. So these are metabolic disorders. So you have three. You have maple syrup urine disease, you have PKU, and you have glycosemia. And like I said, it's a state law that every baby gets a PKU test before they leave, because you have to control it. Like I said, it's a lifelong disorder. Okay. Now the next one we have to talk about is called neonatal abstinence syndrome. It's called NAS. All right. And one of this is a set of behaviors exhibited by infants exposed to substances in utero. So mom is a cocaine user, and so now this baby has abstinence syndrome when he's born because he's not getting that anymore. He experiences like a withdrawal, and early identification is just essential to these babies. So what happens to them? They get from neurological, they have a high pitch cry. Let me tell you, this cry is terrible to hear. It's a high pitch. It's like you can feel it in them, and it's irritable. They have seizures, they have tremors, and they have notable yawning. I've seen that on a test. So you probably want to write that down. It's a high pitch cry, irritable, they're extremely irritable, and they have seizures, they have tremors, and they have a notable yawning. Now, under the gastrointestinal, they have a frantic, uncoordinated sucking. They can be vomiting, and they're a difficult feeder because again, they're withdrawing. And then under metabolic, you put tachypnea, diaphoresis, mottling, mottling. Their color, their skin is not right. It's more cyanotic looking, and the temperature instability. Everything gets affected. And of course, you would have. So what do you want to do for them? Well, you're going to run some blood tests or toxicology, and then you want to hold them real tight, guys. And you want to do that swaddling. You wrap them up real tight, the swaddling effect, and you want to decrease stimuli. Yeah, these kind of babies, just like the cocaine babies, they can't be, all these babies that are born to moms who had drugs in their system, they can't have a lot of stimuli. They're not consolable. And so the best thing to do is swaddle them up, keep them from harm, and they're in the crib and they kind of cry themselves. It's awful. It's awful to see this. It's not fair. So this is infants of diabetic mommies, and this is of course a big one. And keeping the mom's blood sugar is what? In balance. That's called euglycemia. That's the most important factor in influencing fetal well-being, is keeping mom's sugar levels normal. So what their parents look like, they're called macrosomic babies, large for gestational age. And your book has a great picture, and here's a good picture on this PowerPoint. And is there increased risk for birth injuries? Absolutely. And so these babies have to be tested right away for hypoglycemia, because don't forget, if mommy's sugar levels have been up and down, baby's been getting those Snicker bars every day, all day long for 9 months. That's why we got so fat here, right? We're a big baby. What happens though, when you take my Snickers bars away, my blood sugar is going to go down quick. So that's called hypoglycemia. So that's why we test these babies very quickly after birth. And they should be breastfed every 1 to 2 hours to keep their blood sugars at a constant level. A lot of times these babies will be in the NICU, and we have to watch for respiratory distress syndrome. These babies at a high risk for respiratory distress syndrome. And so, you know, you have to watch also for increased insulin production in the baby and decreased surfactant for lung development. So that's why they're at risk for respiratory distress syndrome. Makes sense. And also these babies are increased risk for congenital anomalies, especially if you have a diabetic and like a type 1, and she gets pregnant and her blood sugars are not within norm, she's more prone to increase in congenital anomalies. Okay. So we're at the end now. So here's, you know, don't forget you have 5 math questions, and you guys are pretty good. So you want to keep up with the math. So, you know, you change milligrams, like milligrams to give, mLs to give, pounds to kilograms, milligrams per kilogram, and then you got milligrams to micrograms. So you just want to make sure that you're well versed on that. And there's my little baby at the end. Isn't he cute? It says, stay strong and you got this. And you do. It's a lot, but you have this week. And so take your time and really read through everything. Do your key terms and read your key points. Okay. All right. So thank you for attending today. This is the end of the review for exam number 3.